Morning, everyone, and welcome back to Semel Grand Rounds. Today we have Dr. Hannah Roggenkamp, who will be talking with us about the concept of moral injury and how it relates to many of the issues of the world today, including PTSD and COVID-19. If you have questions for Dr. Roggenkamp, you can use the Q&A button to submit it at any time. And remember to check your email after the presentation ends to fill out a survey for CME credit. And now Dr. DeBonis will introduce this morning's speaker.
Morning, everyone. It is a unique honor to introduce today's Grand Round speaker, Dr. Hannah Roggenkamp. I have known Dr. Roggenkamp since she was an exceptionally talented resident here at UCLA with big ideas, a talent for teaching, and a way of connecting with patients that is truly unique to her. While working with veterans during training at the West Los Angeles VA, she became interested in moral injury and the mental health effects of combat trauma. After graduating, she completed a MIREC research fellowship, specializing in combat trauma and brain injuries at the Seattle VA. She then worked at Madigan Army Medical Center in Washington State for 2 years, treating active duty Army service members. Luckily for us, she returned to the West Los Angeles VA, where she uses her knowledge, experience, and strong therapeutic skills to treat veterans and educate residents about PTSD, moral injury, and psychotherapy. She is currently working on developing a short-term psychodynamic therapy approach to treat the effects of moral injury in combat veterans. Today, she will be talking about the concept of moral injury, both in combat trauma as well as by non-military people during COVID-19. I am so excited for us to all learn from her today. And now I will hand it over to Dr. Hannah Roggenkamp.
Thank you so much, Dr. DeBonis, for that really wonderful introduction. It's very exciting to be here, no longer as a resident watching these wonderful presentations, but actually presenting. So I think we should just jump right into it. So again, my topic today is moral injury, and I'm assuming that really not a lot of people in the audience know what moral injury is, so I'm hoping to give you a taste of it. And talking about it from a military trauma standpoint, but then also from a standpoint of our current crazy situation that we are in with COVID. And as always, I have no financial disclosures, and the views and opinions I will present today are mine and do not necessarily reflect the official policy of the VA or of UCLA. So I'd like to tell you about a problem that we have in the PTSD world. Over the last 25 years, there's been a lot of efforts put into finding good treatments for PTSD since it is such a chronic and debilitating disease and disorder. And the treatments that are sort of the most studied are labeled as gold standard PTSD treatments or evidence-based practices. And they are typically short-term treatments, 12 to 15 sessions. And they're developed from more exposure, sort of behaviorally based approaches and from cognitive approaches. I'm just going to talk about two of them today. The third one, EMDR, which is eye movement desensitization and reprogramming, I'll leave out for today because really most of the good data is in the two of the treatments that I'll talk about. One is called prolonged exposure therapy that, like the name implies, it is based on exposure. So what happens is a PTSD patient will be encouraged to tell the story of their trauma in detail, audio record it, and then listen to it daily until sort of their distress and their anxiety around it decreases. And then they're also encouraged to do behavioral exercises to kind of start approaching things that they avoid, say going to a crowded grocery store or going to a restaurant and sitting with their back to the door, things like that. So that's one of the approaches. The other one is called cognitive processing therapy, CPT. And as the name implies, it's sort of a CPT-based approach, where also patients are encouraged to look at their thoughts and beliefs around the trauma. The thoughts and beliefs they have are sort of considered maladaptive, helping them change those thoughts and beliefs into kind of in a way that ideally will help them and relieve some of their suffering. And as you can see, these treatments, especially PE, they're geared towards something that you're afraid of. in a phobia, like a fear of heights, which I certainly have, the way I would get over it would be to expose myself to increasingly higher and higher heights. And ultimately, hopefully I can, go to the top of a high building and not be scared. So the problem is when we look at the randomized controlled trials of these treatments, they just tend to be less effective in the veteran population. And the other thing that's important is that the trials that were done kind of to establish these treatments as the gold standard, unfortunately, typically compared these treatments to just a waitlist condition or treatment as usual. So not really active treatment. But in recent years, there have been several studies done comparing these treatments in active duty service members and in veterans to an active treatment, such as presence-centered therapy, which was sort of created to be a control therapy, or to transcendental meditation. And what we've been finding is that when you compare these treatments to active treatments like PCT, presence-centered therapy, or transcendental meditation, they tend to be about as good as PE or CPT. There was a recent non-inferiority trial of transcendental meditation where it was non-inferior to PE. So these are just important things that we need to think about when we're thinking about treating PTSD and about these treatments. Another difficulty is we don't have really good long-term follow-up data on these treatments and how patients do long-term. If we have, rarely we'll have maybe a year of follow-up. It's really not enough time from patients who went through these trials to see if they're really getting a benefit out of it or not. And then unfortunately, when you look at just clinical data from patients just in the real world, some studies have found that just retrospective record reviews have shown that like maybe less than 10% actually finish a course of treatment. And my goal with telling you this is not to say, these treatments are useless, they don't help, we need to get rid of them, because that's not accurate and that's not appropriate. But it's to point out some difficulty and some problems that we're having in this, the world of PTSD. And just that we really need to think about which interventions are most appropriate for which patients, and really kind of to recognize the limitations that the treatments that we typically offer really have. And so the question is, why don't these treatments work as well in veterans? And there, can be several different explanations for this. But the one that I want to focus on today is focusing on trauma type. So does it really make sense for us when we think about a traumatic experience, a criterion A trauma, to think that all traumas are created equal? We can use a one-size-fits-all model to treat a sexual assault the same way as a physical assault, the same way as a car accident, and the same way as we would a combat trauma. I don't think really kind of logically this makes sense, but that is sort of a bit of a one-size-fits-all model that we've been doing into this point. And really, we need to think about how that a trauma might affect somebody differently depending on what it is. We know for certain that for some reason, military sexual trauma is actually more likely to cause PTSD than a civilian sexual trauma. So the context of the trauma and the way that the trauma happens matters. So we really need to think about, if we're really doing all patients a service by treating all traumas the same. So I would like to focus on what makes military trauma special and different. But for me to really be able to do that accurately, I do think it would be important to talk just for a couple minutes about military culture and warrior ethos, because it's important to understand it a little bit to really fully understand military trauma. So there's people who join the military. This is an incredibly small percentage of our population who we're trusting to really go against what we consider ultimately human nature and to kill other people, and hopefully do it ethically and kill the bad guys and not the good guys, and spare innocent women and children. This is a tremendous responsibility. It's so important that books have been written on, included this one by Lieutenant Colonel Dave Grossman, which is considered required reading by some branches of the military. But in general, military culture, there's a big focus on that willingness to sacrifice yourself for the greater good, and real selflessness that is really admirable, as well as a trait that I personally really like, which is people who are willing to endure suffering. Military service starts with suffering with your basic training or boot camp. And even if once you've completed all that, depending on what your job is, you can be forced to do long ruck marches with heavy packs in the heat. And that's just something that is part of the deal. Depending on the job, if your job is a combat job in the military, you're not somebody who runs from danger. You hear gunshots and you're somebody who runs towards danger, which is a very different mindset than really most of us have. There's also this incredible emphasis on taking one's job seriously and taking pride in completing it well. And this makes sense because when you think about the stakes that service members are operating under, their jobs may really kind of determine if somebody lives or dies. And so an individual service member would take their job very seriously, and if they fail at it, it can feel devastating. Another thing that is really important is that when people are in the military, they are, especially if they deploy or if they're in combat together, the relationships are incredibly strong. They're stronger than any of us who are civilians could really understand or imagine. They're probably relationships that are as close or closer than a spouse or the way that a parent might feel for a child. And there's a dedication there that's so strong to the people who one serves with. It can be a very uniting thing, and it can also be a painful thing if you lose somebody who you serve with. And then ultimately, I think it's important for us to remember that, like, when you're in the military, you're not a regular civilian. You don't have rights the same way. You know, you can be in major trouble if you just leave your post and go AWOL. That you can be thrown in jail for that. So there's this great responsibility that's placed on hierarchy and leadership, and you know, we really have to trust these people to take care of the service members if they're in leadership. So just, you know, keeping some of these principles in mind, I think would be useful when we're talking about military trauma. So I do want to say that I'm going to be giving some examples of some of the traumas that my patients have experienced. I'll tell you why on the next slide. But I am going to be a bit descriptive, and I want to be sensitive to the fact that for some people it might be really disturbing and it might trigger really intense emotions, which I quite frankly don't really want to do to people. I will say that I won't be talking about sexual assault or sexual trauma. I'll just be talking about military and combat trauma. But if you would like to just put me on mute, not yourself on mute, but me, for the next couple minutes, the next time you see a flower like this on a slide, you can unmute and you can keep listening. So like I said, it might seem unnecessary to talk in detail about some of the things my patients have experienced, but I actually think it is important. And here's why. Because, you know, as a society, we oftentimes don't really want to hear about the things that our service members have to do and are ordered to do, and the things that they live with and they struggle with that ultimately potentially cause symptoms later on because of really how horrendous and horrific these things are. But I believe that the more as a society we can acknowledge them, potentially the less alienated certain veterans will feel. So that's why I think it would be worth for us to spend just a couple minutes talking about some of the things that some of my patients have been experiencing. So I first want to introduce you to the woman on the upper right-hand corner. She's a mother of 3 and she's married. She's working, but back in the Navy, she was a nurse and she served very honorably in the Navy for 20 years. So she came to me with PTSD that was really difficult. It was difficult for her to even think about talking about some of the things that she experienced. But she did tell me about working in a hospital in Iraq in 2005. And she was part of mortuary affairs. So she would go through the bodies of service members who had died in combat. And it is very much kind of haunted by these experiences, by these memories, going through their pockets for their effects. You know, these were typically like very young people, you know, really still children, you know, below the age of 20. And just the his hundreds and hundreds of bodies that she had to process, this still greatly affects her. And this is, you know, a very difficult issue for her, to these memories, to kind of have them come up in her mind. The other thing that she told me that I think is a really important thing to mention is something that she witnessed in the hospital when she was volunteering in triage, because she just wanted to be useful. A young Marine had been brought in from his convoy. It had been attacked with an IED, and this young Marine, his legs were gone. They had been blown up. He had been blown up by the IED, and his legs were blown away. He was pretty well medicated, but he was awake and he was talking, and all he was focused on was getting back out to his men. I want to get back out to my guys. I want to go be with my Marines. He knew that he was not going to be able to go back to them. His legs weren't important to him. To him, it was important that his guys were there without him, and he couldn't do his job being a teammate the way that he really wanted to. I mean, this is a tremendous thing, a burden to bear, that this poor Marine was having to really struggle with, and potentially still struggling with to this day. I can't say. So that's one patient. The other patient I want to introduce you to is the gentleman on the upper left-hand corner. I should also mention none of these are my patient's pictures. They're from the internet. But my patient in the upper left-hand corner, he was in the Army for 20 years. He was honorably discharged as a sergeant first class. And he's somebody, you know, with Purple Heart, shrapnel injuries, this really amazing guy. And I started treating him soon after he left the Army and was retired. And it proved difficult for him to really connect to a mental health provider when he was in the Army. And luckily, he and I developed a really good rapport early on, and we were able to work together pretty consistently for the last 2 years. And this is somebody where he's had 7 deployments, an incredible amount of combat trauma. Most of it that he would tell me was surrounding traumatic loss and the soldiers he had lost who he was in charge of. But like 2 months ago, he told me about an event that happened because the anniversary of it was coming up, of being on this mission in the Iraq War with some special operations folks, and they were kind of hiding out, and a young shepherd kind of wandered close to their hiding place, who was going to ultimately compromise the mission. And it was very difficult for the patient to tell me, and ultimately for him to make the decision. But at the time, he was the one who went and killed that shepherd with a knife with his bare hands. A horrific thing to think about, and he's still haunted by the look in that young man's eyes when the patient was rushing towards him. And he still has that knife because it was his deployment knife that he used. So this is another experience that a patient has had that can be incredibly difficult and traumatic. The last person I want to talk about is the guy in the bottom left. This is a man in his 40s, and he's high functioning, married, working. He was an officer in a special operations unit in the Army. And he told me about a really difficult experience he had leading men in Afghanistan. They were doing kind of a stakeout of a compound. They knew there were bad guys in there, but there was just a question of how to go about getting the bad guys. One option could have been he and his men storm the compound, but my patient, he figured he would lose at least 1 or 2 of his guys, which is a horrific thing to face and something he didn't want to have to risk. The other option, though, if they're not going to go in on foot, would be to call in an airstrike and just bomb the entire compound. The problem with that is they have no idea if there's innocent folks in the compound. And so there was a risk that innocent people would be killed if they did that. But my patient ultimately made the decision, because he didn't want to lose his men, didn't want to risk that, was to call in an airstrike. And unfortunately, while they surveyed the aftermath of the airstrike, they found about 10 bodies of children between the ages of 2 and 12, and also of about 3 women. And this weighs on this patient. It horrified him. And the other difficult part of this is that his men were then angry with him for making the decision to call in the airstrike. They wanted to be able to just go and get the bad guys, spare the innocent women and children. And so they became very upset with him. And so that bond that he had in that relationship was ruptured because of this experience that he had and this decision that he really was responsible for making. And so I kind of want to juxtapose his trauma and his experience with maybe somebody who has a trauma that's based on fear and being afraid and being kind of the victim. Because an assault victim with a fear-based trauma, typically we would think that this person kind of, the worst part about the trauma was that they were attacked, and that was very scary. And that they might have intrusive images of the attack, and that they're now also fearful of going out because they're worried that the attack's going to happen again, and they have reminders of the attack that really bothered them when they go out. This is a fear-based thing. It makes sense that what we'd want to do with this patient is to help them overcome that fear, get back out there, get back on the horse, and also just talk through that experience so that hopefully they don't get quite as anxious and quite as upset when they think about it, and they can kind of go about their lives in a kind of a going back to normal kind of way. But with this patient, it's different. It's not about his life being threatened. It's about something that he feels responsible for that was really, really horrific. And the question is, is this a reasonable kind of responsibility that he feels, or is this unreasonable? I would say if I try to convince him he was just doing his job as an officer and he was just serving his country in the Army, he's thought about all that. That's going to feel very hollow to him. I think for him, this responsibility and this blame is justified. And who am I to say that it's not? And he also has incredible turmoil around sort of this disconnection that he had from his soldiers as a result of really him just trying to protect them. And I'm not trying to defend his decision, but you can see how he was really just in an impossible place here. So really, hopefully it's clear, it doesn't really seem like this was a fear-based trauma that he was experiencing. This is a trauma that is tearing him up inside, that has implications about who he is and if he is a good person or not, since he was willing to sacrifice all these people for his men. How would we help him? Does having him just repeat that story over and over again, does that make sense? I don't think so. So the question is, what is going on with him that potentially we could help with? What is the trauma that he has experienced? So this brings me to talking about moral injury. So moral injury, has probably been around as an idea for a very long time. But the first time it was written about and the first time the phrase was coined was in 1994 in the book Achilles in Vietnam by Jonathan Shea. So Jonathan Shea was a psychiatrist who worked extensively with Vietnam veterans, and from his work with them had a very strong feeling of some of the things that they were struggling with. And he framed moral injury around the betrayal by leaders of what is right in battle. And this betrayal causes disorientation and despair. And I want to read this quote because it's really important. Moral injury is an essential part of combat trauma that leads to lifelong psychological injury. Veterans can usually recover from horror, fear, and grief once they return to civilian life, so long as what's right has not been violated. And this what's right is just so important. The only way I would imagine, you can, one of the ways that you can go into battle is knowing that you're going to ideally do the right thing. And in such high stakes environment, if the right thing is not done, it's going to have incredible consequences. But it's important to say that with Jonathan Shea's formulation, it was about betrayal by leaders who were not doing right by the people who were in their charge. So he created this amazing start, and he's considered a major figure in the moral injury world. But the definition has now been expanded and updated. So now what we say is that the most current definition is the lasting psychological, biological, spiritual, behavioral, and social impact of perpetrating, failing to prevent, or bearing witness to acts that transgress deeply held moral beliefs and expectations. We consider these acts or these events as potentially morally injurious events. And as it's stated here, we kind of think about these in different categories, and they probably have different effects. One is perpetrating violence. One is being betrayed by leaders or others, which leads to dire outcomes, and also bearing witness to human maliciousness or atrocities. And I think, it's important to also know that moral injury is a really kind of relatively new concept. There's an agreed upon definition, but it's not, completely unanimous. And we're really just in the beginning stages of learning about it and understanding it. And it's also important to point out that we don't think that moral injury is like itself a diagnosis. We think that it's more an experience that somebody has, an injury that somebody incurs that then has consequences, which we'll talk about in a second. I think it's also really interesting to think about the fact too that for a lot of our patients, they don't really show symptoms of psychiatric disorders a lot of the time until they leave the military. So society is incredibly important in moral injury. That if service members are still in the society where presumably there's people with shared experiences, including with, who've also engaged in morally injurious things, they're going to still feel connected to that society. But as soon as somebody leaves the military who has a morally injurious experience and kind of goes into regular civilian world, that totally changes. Now they're around people who have not had the same experiences that they have had. And because some of these events can be so horrific for patients, especially with perpetration moral injury, they can feel separate from society. They can feel less than human. They feel kind of bad or tainted. And that makes them want to withdraw, to, in a way, almost protect other people. And it makes them really not want to divulge or disclose out of fear of, one, hurting the person who they're telling the story to just by the horrific nature of it. And two, they're worried about rejection. What happens if they reveal this thing that they did and they're kind of outcast? It's a really painful thing to think about. So these patients oftentimes withdraw and don't feel connected to society, and it can have pretty bad effects, pretty dire outcome. I just want to mention briefly too that religion and spirituality can certainly be a part of moral injury. It's not my focus. There's smarter people, even here at West LA, like Donna Ames, who knows more about the religious and spiritual aspects of it. But, on top of maybe an internal moral feeling of what's right and wrong, if somebody engages or witnesses an act that violates codes that come from their religious or spiritual practice, that can additionally be a burden that they carry and that they struggle to know how to deal with. So, as you can see, hopefully I made the argument that there's more traumas than just the life threat traumas. There's more than just the car accident or the assault. There's life threat self and others, which are pretty self-explanatory. But then there's also the trauma of witnessing aftermath of violence, as the nurse who I discussed earlier had. And there's traumatic loss. Traumatic loss appears to be incredibly painful. If there's a loss of a close military buddy, and that can have big effects. And then we also break it down in moral injury self and moral injury others. So moral injury self is along the lines of committing an act or sometimes failing to prevent an act that is in violation, gross violation of moral and ethical standards. Moral injury others is witnessing or being a victim of an act that is perceived to violate moral and ethical standards. So this is kind of how we categorize things. And when we talk about COVID in a little bit, I'll bring up this idea of moral injury self and others again and see how it applies to the situation that we're in now. And there has been some work to try to parse out different traumas to try to see if we can figure out different reactions that they might cause. Unfortunately, not a lot of studies have been done on this, but It's theorized, and there's a little bit of data backing up the fact that there are kind of qualitative and quantitative differences. This table is taken from Brett Litz's and others' Adaptive Disclosure Manual, which is one type of therapy under investigation for moral injury. So this is the idea that with life threat on the left, you have this immediate reaction of horror and fear and helplessness, and that leads to a conditioned kind of emotional response, and that the way to help that patient is to help them regain safety and mastery. Whereas with loss, the initial reaction is sadness, oftentimes numbness, shock, rage. Sometimes patients will do things in that shock and in that rage after they lose somebody close to them that they then becomes a moral injury self that they later regret. This leads to withdrawal, guilt. Patients really struggle with grief. The grief feels ever present. And ultimately what they need to do is reconnect with the grief and experience it more fully, and then hopefully kind of bring them back to the living and help them reconnect with others. And then with moral injury events, we imagine that the reaction around that event is guilt and shame and rage. It's associated with kind of feeling unforgiven, withdrawal from society, and that potentially the thing that these patients need is kind of reconnecting with others, forgiveness and compassion. And when I say forgiveness, I don't mean abdicating responsibility. None of these patients want to do that. But it's this idea that it's a path to emotional healing and a repair of broken interpersonal bonds. So forgiveness in that way. There have been a couple of research studies, like I said, parsing this out. One of the better ones was done in 2018 by Brett Litz and a group of his collaborators. And we did find that compared to patients with a life threat trauma, those with a moral injury trauma had higher levels of re-experiencing of memories, higher levels of self-blame and sadness. And then patients with traumatic loss compared to life threat had also higher levels of re-experiencing, peritraumatic and post-traumatic sadness, anger. So we really did see differences that are important and presumably really should dictate how we treat these patients. As far as the mental health kind of sequelae of moral injury, obviously PTSD is sort of the most strongly associated with it, and this nice Venn diagram came from a good study in National Guard personnel from 2018, showing the overlap between moral injury and PTSD, but that they're really probably not the same, and that there's aspects of post-traumatic kind of reactions that might be lumped into PTSD, but probably are their own kind of separate thing, like grief and guilt and shame, social alienation. But we also see other things besides PTSD. This isn't just a sort of a trauma-focused thing. This can be more pervasive in the life of the person. It's linked to depression and anxiety in both military and civilian samples, and to lower social support, lower social occupational functioning, suicide risk, substance use, anger. Unfortunately, almost all the studies on moral injury have been done in military, so we don't really have a lot of information about how this plays out in civilian life. And again, I just want to bring up this idea of society, that society plays such a big role in how patients with moral injury go forward in their lives. And this is just an important thing to remember. So I didn't want to leave you without at least some information about how we kind of conceptualize going about treating this. I heard a speaker once say that moral injury is like an amputation, that really is a loss of something, and it takes a while for patients to figure out how to readjust and live in this new world that they live in without this thing that they've lost. And honestly, nobody really knows exactly what needs to happen to treat it, and it probably varies by patient and by trauma, of course. But we do know that there are probably some things that are helpful, certainly individual therapy. And like I said, there's a couple under exploration right now, including a spiritually oriented version of CPT, which is being studied here at the West LA VA with Donna Ames, as well as adaptive disclosure, which is under investigation, as well as another one called Impact of Killing, which is being kind of spearheaded by Shira McGinn, who's a psychologist up in the Bay Area. But probably also group therapy is probably important. Kind of that reconnection with veterans who maybe have had the same experience can be really healing. I think relationship building and helping patients be close with people who are to be trusted is incredibly important. And then meaning making in life. A lot of these patients had really high stakes, important jobs that really, they got a lot of value out of, and finding ways for them to make meaning in their lives now that they're no longer in the military. And for some too, they need some kind of giving back or reparative behavior that can be very helpful, volunteering, doing good in the world to sort of balance the cosmic scales. And then for those who have a religious or spiritual practice, to approach that and to find ways for them to work through the things that they find morally injurious that they might have participated in, and find some healing and closure within their religion. So it's a multi kind of faceted way that we think that these patients ultimately need to go through in order to be able to recover. So I hope that gave you all some sense of moral injury, at least maybe kind of in a beginning taste of it. So some of you might not be very happy to see this guy's face, but as I was preparing this talk, I was thinking about moral injury, obviously, and just seeing COVID unfold in our society. And something kept popping up in my head, especially when a lot of the kind of the PPE issues were going on early on, and it felt like potentially leadership in our country might not be taking things as seriously as I would have hoped. I'm not trying to make this political, but just trying to help you understand my thought process. And I kept coming back to this thing that Donald Rumsfeld said, which really enraged me back when he said it, and it just kind of was starting to ring true for what I was feeling in regards to my colleagues in New York City, when New York City was really greatly affected. Donald Rumsfeld said about the war in Iraq, when he was talking to Marines, and the Marines were bringing to his attention that they were being kind of ordered to go into war with these cloth-sided Humvees. And Donald Rumsfeld said, as you know, you go to war with the army you have, not the army you might want or wish to have at a later time. And it made me think, we go into a pandemic with the healthcare system we have, not the healthcare system we might want or wish to have at a later time. And, pretty early on, we started to see news stories coming up about, the challenges that that healthcare professionals were facing. And, I had sleepless nights thinking about what was going on in New York City. And really quickly, actually, the news media started talking about some of the effects that this pandemic was having on healthcare providers. So as early as early April, the BBC had a couple of news stories about moral injury and these young doctors being asked to play God. This was picked up by multiple different news organizations. And I found this New York Post cover, and it just really broke my heart. But also illustrated this point of these people were working in the hospital, putting their lives in danger. And while I don't think the New York Post is the most reputable news source, this idea that they felt like they were being treated like trash, or that's what the perception was. It really hit me on a deep level. And then I don't know if you remember Dr. Lorna Breen. She was a director of an ER, I believe, in a New York City hospital, who had been working with these very sick COVID patients in these overloaded hospitals, ultimately contracted COVID herself, and then shortly thereafter committed suicide. I don't know why she committed suicide. We can never really know, but I know her father, who was a physician, you can see it in the headline, his feeling was it was the job that killed her. And it's a really kind of painful thing to think about, but obviously this pandemic has taken an enormous toll on healthcare providers in general. And just to understand why that might be, I want to briefly kind of juxtapose warrior ethos with physician ethos. And while I am focusing on physicians, I want to say that some of this obviously applies to anybody who volunteers to do healthcare or mental health care work. So both professions have this real focus on kind of professionalism and decorum. I think because of how stakes the job ultimately is, a lot is expected of soldiers, and a lot of it is expected of us as physicians. There's also these kind of real beliefs that carry us forward. In medicine, it's first do no harm. I know that in the military, there's this desire, to get the bad guys, and they see themselves oftentimes as sort of protectors of the innocent. I also think about how much physicians sacrifice. Shortly, I think before I started residency, people were still working for 36 hours at a time. I don't know any other profession that thinks that that would be acceptable, but in medicine, it seems just fine. And that type of sacrifice really reminded me of the sacrifice that military service members are willing to undergo. And then suffering to obtain the title of, whatever job a military service member wants to have, and the 4 years of medical school, and then the 3 to 8 years of residency that physicians go through. It's a real hazing process, it feels like sometimes. And then the negative sides of the jobs also seemed kind of analogous, that if the role is abused, enormous harm could come. That's true in medicine, and it's true in the military. But also that, in the military, there is a push to try to make seeking mental health care more accessible. It still is kind of a struggle. And certainly people with high-level security clearances, there's a risk that they'll lose their security clearance if people know that they're getting mental health care. So it just makes it really difficult for people in these types of high-stakes jobs to ultimately get the help that they need. And again, I want to say that as much as I'm focusing on physicians, this is something to some degree that probably most or all mental health and healthcare professionals face. It's also kind of worth us just understanding briefly that all of this does exist on a spectrum. This graph here on the x-axis is sort of degree of spiritual harm and impairment, going from very little on the left to extreme impairment on the right. And then the y-axis talk about event frequency and how prevalent it is in the population. So, moral challenges and moral frustration, that's something that we probably deal with on a regular basis. And becoming less frequent but more distressing are real moral stressors. I would imagine, unfortunately, that even before COVID, people in the healthcare system were dealing with major moral stressors every single day. I can think of being a resident, being on call, and having some really, really severely mentally ill patient who had just Medi-Cal insurance, and having to send them, to a hospital where I thought, because we can't take them at UCLA, that there's a chance that they'll get subpar care somewhere else. And it's not to point fingers at UCLA. It's just a quandary that I remember struggling with. Hopefully, morally injurious events don't happen very often, but there's a chance that on this right side of the spectrum, that these events are happening more often during COVID. So what do we know about moral health during COVID? We do know that moral distress is likely to occur in any healthcare crisis due to the inability to provide optimal care. That's ultimately why any of us wanted to be in healthcare, because we really want to help people and do the right thing by them. So there have been some papers published in journals, but most of them are more like position papers, and we really don't have a lot of data yet on moral outcomes or moral injury in healthcare providers at this time. There's some studies coming out about more, mental health in general and those types of outcomes, but not really so much on moral injury. And it's important to know too that nursing had us beat. There was a moral distress scale published in 2001 within the nursing community. They've known about moral distress in their jobs for a very, very long time. And now some of the symptom scales that we use to measure moral injury are being developed for healthcare professionals. So there's a real interest in this topic right now. And so it's important to remind ourselves again, the moral issues that healthcare providers are encountering, really probably have less to do with the threat to their own lives, but their own struggles within this system that is putting them in very, very difficult situations. Because remember, when we're talking about moral injury, we're talking about actions and events that transgress deeply held values in a high stakes environment. And ideally, our healthcare providers hold very strong values about what they should and shouldn't be doing to help patients. I found a quote from the British Medical Association saying, although doctors will likely find these decisions difficult, if there is radically reduced capacity to meet all serious health needs, it is both lawful and ethical for a doctor following appropriate prioritization policies to refuse someone potentially life-saving treatment where someone else has a higher priority for the available treatment. These are grave decisions. And I appreciate that, they thought to write that down. But, think about some critical care physician who's having to make the decision who gets a ventilator. And, sure, they know that whatever decision they make is lawful and ethical, but is that going to resonate with their moral emotions that they have? Are they going to be able to be at peace with the decision they made? I think that would be very, very difficult. I think there's a chance that you could have a moral injury self event with that type of decision having to be made. I think there's rampant opportunities for moral injury self and others. I would imagine that nobody wants to break bad news to the family of somebody who's dying of COVID, and you have to do it over the phone. There's healthcare providers talking about having to be with patients to the end of their lives until their deaths, and their families aren't around. I mean, this is an incredibly painful thing to watch and to be a part of. There's also concerns about healthcare providers bringing COVID home with them and endangering their family, something very scary. And then what was brought up in one of the BBC headlines is this idea of young doctors playing God, people being kind of pushed into roles that they aren't trained for and aren't prepared for, maybe don't even want to do. And that just the struggle with that and making a mistake, and whose fault is that? If you're somebody who's not really trained to do the job, but if you're somebody who takes your obligation and your job seriously, you're still going to feel responsible. So there's so many different avenues that are available in a pandemic like this in healthcare for a morally injurious event. And what is probably also happening, especially in the moral injury other category, is this idea of institutional betrayal, that people are seeing institutions kind of maybe not treating them with the best interest in mind. And there's something very powerful about using moral injury to talk about an issue like this, as opposed to burnout or compassion fatigue, because it puts the focus and the emphasis on the system being problematic. The system violates morals, as opposed to there's something wrong with the patient inside of them that they need to work out. And unfortunately, the sequelae of this moral distress is most likely burnout and exhaustion and compassion fatigue, substance use, sleep disruption, physical symptoms, guilt, shame. So it's having a major impact that we'll probably really only understand once this is all said and done. So what to do? I'm not a policy wonk. I'm not a policy person. So I would not be the person to put forth some kind of very detailed plan. This topic deserves a lot of discussion. Ideally, we're not going back to business as usual once this is all done, considering that for the most part, healthcare providers were in some moral distress even before COVID. But this is obviously a systems issue. There have been injustices and imbalances in the healthcare system that are just being amplified right now that need to be addressed. It's also important to think about all of us banding together and advocating both for ourselves and our profession and for our patients. But also there's a role that people in power have to provide adequate education to their staff on what's going on, and also to take real responsibility for what's going on. It can be really morally injurious if the person in charge isn't taking responsibility for a situation that they have a lot of control over. And really, mental health resources need to be available when people are reaching out to seek help, so that they don't drown alone. There's other things that potentially, shared decision making in a high-risk situation, as opposed to just having one provider do it. Ultimately, though, it's human connection. And I know COVID has messed with that human connection thing, and made it very difficult for all of us to really feel close. But as much as we can band together and we can, keep teams in hospitals together, and encourage people to band together and work together, that kind of connection tends to also be protective against moral injury. The more we can stay connected to each other, the less isolated we feel. There have been a bunch of kind of papers put out about approaches to more, mental health problems and moral injury, and proposals on different steps that healthcare institutions could take. I've listed them here. One of them was by our own Dr. Mioto. But again, this is outside the scope of my talk, and I encourage you, if you're interested, to check those resources out. So this is actually all from me. I want to thank you all for your attention. A lot of thanks also goes to my father on the left, who was in Vietnam and the Navy. My guy in the middle is my brother-in-law, Mike Piscopo, graduating from boot camp. He's taught me a lot about the military, as has my husband, who's there on the left. So I thank you all for your attention, and happy to discuss for a few minutes.
Thank you, Hannah. That was an incredible talk. And while we're waiting for some questions to come on, I just wanted to thank you for sharing your experience as well as those stories. I know it is really difficult to hear, and I do think it serves a really valuable purpose of having us understand what our servicemen and our veterans are experiencing and what they're going through. So thank you for that. I was hoping, I'm kind of distilling some of the questions down that have come down. I think people are curious to hear a little bit more about what might be some of those reparative experiences that you were describing. I think one of the questions asks, have you seen vets who've gone back to Vietnam or who are able to reduce their symptoms by having some type of experience that helped them feel differently about the experience?
Oh yeah, that's a great question. So I did have a patient who went back to Vietnam. I didn't treat him for very long, but I have heard a lot of stories about those experiences, and it can be a very beautiful thing for Vietnam vets to be able to go back. Really painful, but I think probably what I've been told and my sense is that the thing that is so moving to them is the resilience that they see in the Vietnamese people, and the open-hearted way that they welcome the veterans back. I mean, that is what, to me, is probably the healing thing, is seeing that these people, even though they were greatly affected by that war, they persisted, and they're still open-hearted, and the hearts haven't hardened to the veterans who are coming back, who are obviously still struggling over the experiences they had. So I think that comes back to that connection, right? These veterans were feeling isolated, not connected to the Vietnamese people, and were struggling over the fact that they had been participating in things that had harmed these people. They come and get to meet them and make that connection, and the healing can really start, because it feels like we're together in this, and we both struggled, but we're all moving on together. So I think that's probably the really beautiful thing that can come of going back to Vietnam in that kind of a situation. As far as other reparative things, it kind of, that's sort of unique to every patient, I would say. There's so many organizations that crop up that kind of attempt to give back. One I would comes off the top of my head is a company called Combat Flip Flops. And this is a bunch of Green Berets who are no longer in the Army, but they have a company where for every kind of pair of shoes that they sell, they donate money to send a girl in Afghanistan to school. So, it's just their way of feeling like they're helping and they're doing something in this place where, a lot of bad things happened. But, I think it can be different for everybody. I think for some people, it's finding a job that is meaningful, or it's being a peer support person and helping other veterans, or it's doing some kind of service thing, like maybe joining the police force, or being in government, or joining the healthcare system. So it's something that feels kind of generative, and creating good in the world is sort of the things that I think about. And when I bring up this idea of a job with meaning and something reparative, patients always really light up because it's like that thing that they've wanted but nobody else has brought up before.
Right. And it sounds like a realignment with their moral compass. And I
Yeah.
can imagine with your description of the amputation that would potentially give them that back a little bit to feel more aligned with their moral compass.
Yeah, it's like a little kinetic hand.
I have one question. How are you addressing patients dealing with moral injury that feel that that they insist that they don't deserve forgiveness? And I imagine that's a really big one where it's almost like they feel that they deserve to be punished.
Yeah. And I think that like there's nothing that I could say against. I can't, because the only other way I could contradict them is say, no, you don't deserve punishment, which that's not my place to say. And that would be for them to know, and if they have a spiritual practice, for them to review in that way. But what I'll ask patients is, how long have you been suffering, and how much have you been suffering? They've been suffering a lot of times for years and years, and I'll ask, like, well, when is it enough? Like, when have you kind of bashed yourself in various ways to the point where your life is not going anywhere, you're feeling isolated, you're not being productive? Like, when is the suffering enough? Hope and to see if they can kind of acknowledge the fact that they really have suffered. And they might say, well, it doesn't matter, I still did X, Y, and Z, and I need to be punished for it. And I think it also shows sort of a bit of a difference of kind of understanding of what forgiveness is.
Mm-hmm.
To me, self-forgiveness especially, it's not about saying it's okay what I did, or it's somehow acceptable, or wanting the person who was wrong to forgive them, because that's also expecting something from that person, and we shouldn't expect anything from a victim. But self-forgiveness is all about ultimately, like, wanting to find a way to heal and wanting to put the past into the past. We could try to lash ourselves our entire life, but it's not going to make that experience be undone.
Mm-hmm.
We have to put it in the past, learn from it, not say that it didn't happen, but learn from it, and ideally move forward in a way that maybe would honor the people who were affected by the thing that you did. So it's a tough kind of thing to navigate, but I think there's ways to help patients see that self-forgiveness isn't it doesn't mean no longer suffering or not having responsibility.
Thank you. I think that so many questions and not a lot of time. So maybe one other one. I see a couple of people ask a question that kind of circles around culture, and if you have noticed cultural factors that might contribute to people experiencing more severe moral injury than others, or the role that it might play.
Oh, yeah, absolutely. And I think that, like I was saying earlier, like, I think the society that the moral injury happens in has a huge effect. But, as I think, like, it also depends on, I'm just thinking about, I wanted to mention race briefly, but it's just too much to talk about. But you also have to think about sort of like what kind of cultural baggage and maybe cultural oppression or anything that the person is coming into that situation with. I think about, the Black Indigenous people of color who were in Vietnam, who had been drafted in, had no choice, and were coming in from an environment where they didn't have equal rights. And then to be further traumatized by the military. I mean, it's just this incredible burden of trauma. It's a little bit of a broad question otherwise with culture, but if people have specific questions, I'm happy to discuss more, because I know we're probably out of time.
Yes, I think that's great. I think we are out of time. And I just want to thank you again for this. And I wish we had more time to talk, because it's a topic really worthy of a lot of discussion. So thank you for introducing this concept to us and helping us think about it in a way that might apply to both ourselves as mental health care providers, as well as our patients.
Awesome. Thank you. Thanks for inviting.